You all know that guide catheter support is the key to successful PCI. The function of guide catheter is monitoring blood pressure, injection of contrast, and advancing wire, balloons, and other devices. So, how it differs from the diagnostic catheter? The guiding catheter shaft is stiffer. It is reinforced with three-layer construction, larger internal diameter, and shorter and more angulated, non-tapering the atraumatic tip. So, key factors enhancing guide catheter supports. Catheter size, the larger the catheter, the more the support. The coaxial alignment is more important. Catheter support point two things. One is the angle formed between the guide segment, abating contralateral aortic wall, and maximum support at 90 degree. And amount of aortic area secondary to curve rest on. And deep intubation is another technique to get support, and physical characteristic of the catheter is another important thing. This is the theta angle, the angle formed the secondary curve with the opposite wall of the aorta. The more the wider angle, the greater the support. How to get support? There's two types of support, the passive support and active support. The passive support it referred to backup support obtained when a catheter is inserted into coronary artery and left there. And it depends on its stiffness, size, shape of the catheter that allows secondary curves which rest firmly opposite to aortic wall of the aorta. So how to maximize passive support? Using guide catheter of supportive shape, left side like Voda, EBU and XB, right AL hockey sticks, using longer sheath to overcome the iliofemoral and brachiocephalic tortuosity, larger guide catheter the better support, and pushing Ikari or left a jerkin, assuming power position until the secondary curve is sit on aortic sinus. And the active support is required manipulation to achieve additional backup power, positioning the guide to sit well on aortic root or advancing further deep intubation. This is showing the, when we select the guide catheter, we should consider the points, it is right or left, location of the ostium, high, low, or totally anomalous, ostial lesion associated, or take up of the aortic root size. And this is the aortic root width. And this showing the length of the curve, which means it is a distance between the primary curve and the secondary curve. And this slide showing the first one JR, simple coaxial alignment without support, and hockey stick coaxial alignment with extra support from sinus of the valsalva, and EBU catheter coaxial alignment with power support from opposite wall of the aorta. And coronary ostial orientation is another subject to consider during selection of the guide catheter. It could be high, low, anterior, posterior, or the orientation may be horizontal, inferior, superior, or Schaefer group. And this slide showing there is tortuosity on iliofemoral junction. If we use the larger sheath, it would give further support to the guiding catheter. And how to maximize support on active support? It is a deep intubation of the guide catheter, body wiring. Body wiring may be parallel, side branch wiring or anchor technique, anchor balloon technique, classic anchor balloon, coaxial anchoring or distal anchoring, mother and child technique, and guide catheter extension like guide liner, guide drill, or telescope. This slide showing the ostial artery lesion. So here we use the two body wire. Where is body wire to overcome the support of the right coronary artery. This slide showing there is no lesion on LED, but we keep a wire on LED. It is the anchor wire technique, and we do the PTC on the circumflex. And there is another technique, anchor balloon technique. Anchor balloon described in 2002, and balloon inflated in non-target side branch of the vessel. This slide showing there is a lesion on this obtuse marginal, but we saw the second slide that when we're pushing the balloon, the guide catheter coming out of the ostium, but we put a wire and keep a balloon on the another branch for anchoring balloon technique, and then the balloon crosses the lesion. This is an example of anchor balloon technique. And mother and child technology, another technology, it is a guide or extension catheter. And the next, the modified mother and child technique is the guide GILA or the guide extension catheter. So guide extension catheter benefits, it can introduce through Y connector, less risk of air embolism, easier control of mother catheter, more selective injection, easier achievement and removal ability, and various sizes are available. So precaution not to introduce between 10 millimeter, not to introduce less than 2 millimeter size vessel, not recommended for cerebral and venous system, should not push when there is a resistance. And this is the diagram showing the guide extension catheter and the right coronary artery. And this is the use of GuideZilla. It's the angiogram right torsus, right coronary artery, or distal eccentric plaque. We change the guide catheter to AL1, then passes the wire and GuideZilla. With the support of GuideZilla, we do the angioplasty of the tortuous vessel. This is the final result. And this is the example of deep intubation. It is right coronary artery. There is distal lesion. We deeply intubated the right coronary catheter, guiding catheter to have support and do the angioplasty. And deep intubation, this is the example of deep intubation of the left main coronary artery. The patient was presented with 22 years female patient presented with acute myocardial infarction. We are doing the PTCA, but the tortuosity of the radial and brachiocephalic artery, we could not stable the guiding catheter. Then we deeply intubate the guide catheter into the left main coronary artery and did the angioplasty. So helpful steps during difficult intervention: preparation before procedure, larger guide catheter, take longer sheath, utilize extra back guide, extra support wire. And when held up during procedure, exchange the software with stripper wire through microcatheter, body wire technique, anchor wire technique, mother and child or guide extension catheter technique, anchor balloon technique, and deep engage the guide catheter with anchor balloon technology or mother and child technology. So take home message: proper selection of guide catheter should be done considering the width of the aorta, origin and thick of the coronary artery and osteal disease. Larger the size, better the support of guiding. For proper active support, deep intubation of guiding catheter may needs to be done. Body wire, anchor balloon technique are sometimes helpful. Use of guide catheter extension is an excellent tool for maximizing support. Meticulous analysis of angiogram with proper planning is most important for successful outcome. Multiple techniques may need to complete a single procedure. So thank you very much for patient hearing.
Thank you, madam.